Okay, so again, good morning. So our discussion for today is on brachial plexus. So basically, the way to remember the number of roots are actually with the mnemonics. Just remember how many fingers they have in one hand. So you mentioned that the number of fingers in one hand is actually 5. So we start with C5 also. Then followed by, of course, by numerical. You have your C5, C6, C7, C8, and of course, you are the only one with 5 fingers. Okay, guys? Next is you from your discussion before that this one is would be represented as the roots. Sometimes you labeled it's Robert Taylor drink coffee and then followed by the trunk or sometimes the surname of Taylor. So just to, have a recall of, and then Robert Taylor, and then sabi nila, minom siya ng kape. So drink. Okay. And what's the color? Coffee. And of course, what's the drink? Coffee. And then the color is black, supposed to be, not blank. So from there, Robert Taylor drink coffee. So this would be your division. And then division, and then chord. And of course, your branches. These are the peripheral branches. So that's how you remember it, actually. And then the coffee for chord and block for branches. Any questions so far? And then you're familiar with what we call yung jack and poi. Okay? So you have your bato-bato pick, you have the rock, scissors, and paper. And definitely, I'm going to use that for the remembering this. So jack and poi, and you will have to adjoin the, you look at my fingers, you have the index finger and the thumb, and remaining the middle finger, and you have your ring finger and the little finger. So let's do that together. So let's combine. So we'll put the arrow here. So this one, laki ng arrow. And then this one, and this one also your C8T1, which is your index finger, and our way to remember it. And then by anatomy, this is actually upper, this would be middle, and this would be lower. Okay, so C5 and T1 would become your upper. Sometimes they labeled it already as superior. Okay, and then you have the middle, and you have the lower, or sometimes they call it already now inferior, which is anatomically correct if you think about it, right? So please let me know if you do have question, and everybody can follow. So from here, you have now the branches, you have the trunk. Then you look at now the division. So you have 3 trunks. So definitely you will have 3 anterior divisions, and you will have 3 posterior divisions. So let's join together. Okay. So you have from here, let's label that as, red na naman. Okay, teka lang. Let's make use of another color. So let's say yellow. Ba't hindi naging yellow? Ano yan ang yellow? Ayan. So you have now the anterior division. The anterior division of this. Okay. And then you have the remaining anterior division for the lower trunk. Now for the posterior division, let's color it green. So that would be your posterior division, and the posterior division coming from the lower trunk. Okay, so can you still follow, guys? Can I see a reaction like can have thumbs up, mga ganyan. Okay, so this would become now anatomically correct. So the anterior division of this one and the anterior division of the middle trunk follow the course of your forearm that is lateral, and then follow for your middle finger, ring finger and little finger joined together, right? And then becomes your having your anterior division, and here you will have your medial. And then on the posterior, one posterior, one posterior, one posterior. These are actually located on the posterior aspect of the hand, posterior aspect of the forearm. So we'll label that as posterior division. Okay, so this would be your lateral cord, and then you do have your posterior cord, and this would be your medial cord, right? So from there, you will be able to understand now lateral, follow the course of the lateral, okay, lateral, and it goes into this area, the arm, which is your anterior aspect, and what nerve is actually your musculocutaneous branch, okay, or musculocutaneous nerve. So we'll use the, okay, so you will have now branches for that. Here you will have your ultra, I'll explain later. Okay, so we're now on the branches. So here you do have now your musculocutaneous. Anatomically correct, guys, because you're following on the lateral cord, lateral aspect, and going to this area which is supplied by the musculocutaneous nerve. And these are your biceps brachii, brachialis, and brachialis or DCB muscles of the anterior aspect of the arm. And then, do not forget that lateral starts with letter L actually. So therefore, you have another branch there that would be your lateral pectoral nerve. So let's label that lateral pectoral nerve. So it starts with letter L. Okay. Now what about here? So you have your upper subscapular. You have your lower sub. Then you have thoracodorsal. Thoracodorsal is actually the middle. And then radial and axillary. So I called it ultra. I am sure you're familiar with ultra. So that should be your mnemonics for that. Okay. So let's try to put there ultra. Okay. And then all here on the medial side, the medial cord, all will start with letter M, except except ulnar, of course. Okay. But all here, let's start with letter M, middle cutaneous to the forearm, medial cutaneous to the arm, and the medial pectoral nerve. Okay. So let me label. So medial cutaneous to the arm or to the forearm. And you have medial cutaneous to the arm. And of course, you have your counterpart there, your counterpart on the other side, which is your medial pectoral nerve. Okay. Now, what about the median nerve? The median nerve is coming from your lateral cord, a medial cord, and your lateral cord. Join them together. My mnemonics for that is just oppose this, the index, the little finger, and the thumb. You will have your forming letter M. So 1, 2, 3. That's letter M. So I would label that as median nerve. Okay, so from the median nerve, that is actually coming from there and from there. Okay, so I hope you can follow, and then there are more branches. So let's identify them further. You have from the C5, this is C5, right? C5, C6, C7, C8, T1. So C5 pointed to the back. Okay, so you're pointing to the dorsal scapular. So let's have now the other branches connect to. So we have here at this point, which is actually your dorsal scapular nerve. Okay, so nerve lang lahat para lang magkasya. But of course, you have the branches coming from the superior or the upper trunk. And that is C5 and C6 forming the trunk, point across your chest and pointing it to the muscles at the top of the shoulder, which is your supraspinatus, and you're pointing to the clavicle. So we'll have now nerve 2, suprascapular nerve, and then nerve 2, subclavius. Right? Okay, there's more. So we have what we call C5, C6, and C7 coming from the roots. And what letter are you forming is actually the first letter of the nerve. And that would be your C5, C6, and C7. So that would be your lateral, no, not lateral, sorry. It's a long thoracic nerve. Okay. Can you still follow, guys? Any questions so far? Can I see a thumbs up or reactions among our students so I'll be able to, okay, so great. Now, let me refresh it again. So how many fingers do you have in one hand? 5. So you start with C5, C6, C7, C8, T1. And then you do the jack and poi. What will happen? You're actually doing the adduction of this one and the thumb, remaining middle finger, and you have your little finger and the ring finger. And that will become labeling them as upper trunk, middle trunk, and the lower trunk, right? And so from the upper trunk, you follow the course anatomically using your forearm that is following the lateral margin of the forearm. That becomes your lateral cord. For the C81 becomes the lower trunk, follow the course on the medial side, that's become your medial cord. And I said that one division of this is anterior, anterior, anterior. So there are 3 anterior divisions. There are 3 posterior divisions also. So being the upper, so gets the first 2. So that's become your lateral cord. And remaining anterior division becomes your medial cord. And all the posterior division will join together, forming now your posterior cord. We said that follow the lateral cord, actually along the lateral margin of the forearm, and direct your attention to the arm. And that arm is actually supplied by musculocutaneous nerve, wherein you have the muscles biceps brachii, coracobrachialis, and brachialis. And the remaining nerve is named, starts with letter L. That would be your lateral pectoral nerve. Along the medial cord starts with all letter M, medial cutaneous to the forearm, medial cutaneous to the arm, and of course your medial pectoral nerve that would join with lateral pectoral nerve to innervate later on the pectoralis muscles. We learned that the branches coming from the posterior are actually ultra. So ultra, like you have your upper subscapular, lower subscapular, thoracodorsal, then your radial. This radial supplies this one, and your axillary supplies that one, which is your deltoids and the teres minor. So anatomically, you can remember it. All the posterior cord are located posteriorly. Posterior aspect of the hand, posterior aspect of the forearm, then the lateral posterior lateral aspect of the arm, which are deltoids and the teres minor, and then the muscles innervated by the upper and lower, your latissimus dorsi. So it makes sense, right? And then for the median nerve, approximating this one and this one, you oppose them together. And what letter will you form? Imaginary, you're forming letter M. And in the signed language, right? It's actually letter M, di ba? May ganyan pa yan eh. So ngayon, I'm just using this one. You're forming letter M. And that will be your median nerve, which is, its action is flexion of the fingers and flexion of the wrist. And of course, for C5, C6, C7, the roots, you're getting it from here. And that starts with letter L, that's long thoracic nerve. Remember, this is roots. So 5, C6, C7. And of course, the roots at the C5 level, if you're pointing at the back, it's actually your dorsal scapular nerve. And from the trunk, you combine them together, cross down your chest, and you're pointing to the supraspinatus and to the clavicle. So for the location, suprascapular nerve and nerve 2 subclavius. Okay. Now, of course, we will not end up with that. Let's apply it in clinical correlation. I want you to remember that you don't examine this specific nerve, but you do examine the muscles, right? So how are you going to apply the concept? So let's start with the injury to the brachial plexus. So let me put an arrow, or for example, if you're going to cut the, okay, let me use another color, green. So let's say, let's cut this, right? Double cut, okay? So you're actually injuring now the upper trunk. Let me go through with the other one. You're injuring the lower trunk. And what do we know if it is actually upper trunk? Your upper trunk injury is actually your herb Duchenne, right? You're familiar with it. So I want you to understand the clinical correlation of this so that you will remember the discussion on neuroanatomy. So your attention, please. Okay, from the upper trunk, I want you to follow the discussion, the drawing where I'm pointing my arrow now at the break of the upper trunk. So follow that. What are the branches that will come out from the upper trunk? Suprascapular nerve and nerve 2 subclavius. So what muscle will be paralyzed at this point? The muscle innervated by your suprascapular nerve is supraspinatus. And what is the action of supraspinatus, guys? It's actually your initial abduction. So you do this, right? So when you ask the patient to do that, the patient cannot do initial abduction because you have a damage at the upper trunk. Now, furthermore, if we're going to follow that the principle of action potential, there will be no action potential following to the lateral cord going to lateral and musculocutaneous nerve. And what will be the manifestations? Again, at the arm level, your biceps, you cannot flex your elbow, you cannot even raise your shoulder because the musculocutaneous nerve innervates the biceps brachii. So, what would be the clinical presentation? The patient would be like this, cannot abduct, so naka-adduct. The elbow cannot flex, so therefore the elbow is in extended position, right? Now, let's look at the lower trunk. Is our lower trunk affected in Herb Duchenne palsy? No, right? Because we don't have connections with the upper trunk. So, lower trunk, medial cord, so you have intact sensation on the forearm. So you test on that. You have intact sensation on the arm. And of course, your ulnar. The ulnar is okay. So the little finger and the index, little finger and the ring finger can flex easily, right? So that would make sense now. Now, what about your posterior cord branches? Posterior cord, you have the branch coming from the upper trunk. So what are these? Dalawa spared. Yung isa ang affected because it's coming from the upper trunk. But still, you look at the branches. So you have upper subscapular, lower subthoracic, radial, and axillary. So if you think about it, the play of agonist and antagonist. So yung flexion ng elbow, sinong kaalaban niya? It's the triceps, right? But the triceps, even if innervated by the radial, it's not much affected because you still have the branches of posterior coming from the middle and the lower. So what will predominate now is the weakness on the elbow flexion. So mas malakas si extension. That's why ang position ng elbow mo naka-extend. What about the wrist, which is innervated also by the radial? So if you're going to trace the median nerve here, has a contribution from the medial cord, has an end contribution also coming from the lateral cord. So at the arm level, malakas si radial, but at the wrist level, sino mas malakas? Radial or median? Median is like this, radial is like this. Sino mas malakas? And you still have the ulnar component. Therefore, the position of the wrist is flexion or extension. Mas malakas ito, di ba? So the patient will be on flexed wrist. Okay, so that's how we understand the movement effect. Now, what about your suprascapular nerve? We said that it is innervated by innervating the supraspinatus, but you have the upper and the lower. Thoracodorsal is extension of the shoulder, right? So, mas malakas ngayon yung, ano pa yung function ng supraspinatus? External, right? External. So, mas malakas yung internal rotators. Correct? So, ngayon, ang itsura ng kamay mo, naka-adduct because, bakit ba naka-adduct yan? Because you have your medial pectoral nerve, your pectoralis muscle that contribute to adduction of the shoulder compared with abduction, mahina si suprascapular nerve. So, naka-adduct, mahina si flexion, kaya extension. Mahina si extension of the wrist, kaya naka-flex. So, mas malakas si internal rotation, iikot siya ngayon. And that's what you call now your waiter's tip deformity. Naintindihan ba yon kung bakit nagkaroon ng concept ng waiter's tip deformity? So, that's what I'm driving up. Hindi lang basta minemorize mo, but I'm basing it now with your analysis of the brachial plexus. Is it clear, guys? Yes. So let's move to the next, which is your lower trunk. And that's what we call now your Klumpke's palsy, right? Klumpke's palsy. Okay. So ano naman ang peculiar with this? I made a drawing already to cut the lower trunk. See, if you're looking at it now, it will branch to medial cord. May portion siya towards the posterior cord. Kaya lang mas malakas ang dalawa because you have two branches coming from the superior and one from the middle. One from the superior rather, one from the middle. So what is greatly affected are your medial cutaneous of the forearm. So you test the sensation here. You ask the patient, do you feel anything here? Do you feel anything here? And if you look at the ulnar actually innervates what? The FDP, right? Posterior digitorum profundus, flexor digitorum profundus of the ring finger and the little finger, right? So hindi niya kaya yon. But nakaka-flex siya because your flexor digitorum superficialis is innervated by the median nerve, right? So naka-flex siya. But which one is stronger now? Is it the flexion or the extension? I mean, the ulnar side or the radial side, which is stronger now? Remember, there is agonist and antagonist. So let's analyze. Sa ulnar, you have the flexion of the fingers. You have the radial, which are actually extending the fingers. Now, which is stronger? You have two branches coming from upper and the middle for the posterior cord becomes your radial. So sino sa palagay niyo malakas? Si radial ba o si ulnar? Radial. So therefore, ang itsura ng daliri mo, nakaganon ng patient. Kita nyo, naka-extend siya. Correct? Yung claw hand deformity. Claw hand din to, but ang real claw hand for ulnar and clamp-kiss is actually extended dapat yung proximal phalanx mo kasi mas hinihila siya ng radial or extensor tendons of the radial nerve. Ito, naka-flex siya not because it is strong, but because by virtue of tenodesis effect. Nahila niya to eh. Kaya akala mo mas malakas yung flexion, but actually it's not. But because of the pull of the extensor mechanism. Is that clear? So I want you to understand that the real claw hand of ulnar, the proximal phalanx should be extended possession. Okay? That should be clear, guys. I'm sure that was not emphasized, but you have now your clue for that claw hand deformity. Oh, take note of that. Extended proximal phalanx. Para may clue, no? Okay. Do you have any question for the brachial plexus injury? Okay, so that is the main meat of analyzing the brachial plexus in relation to movement, agonist and antagonist. So let's just look at the specific branch. So when you're looking at specific branch, let's say, let me cut, for example, like this one, ikakat mo to si musculocutaneous. So very easy lang. Ano yung weakness mo doon? It's just the biceps brachii and yung coraco. So anong action nun? It's flexion of the elbow and flexion of the shoulder. So when you ask the patient, localize it, ay hindi niya ma-flex. Pero all other fingers the patient can do, can abduct. So therefore, it's only musculocutaneous injury and it's not a herb Duchenne palsy. Are you getting the connection? Now, what about if you are going to cut the median nerve? Okay, you cut the median nerve. What are the actions of the flexion of the fingers, flexion of the wrist? You have pronation or supination? Pronation, supination for the median. You have the jewel. It's actually pronation, di ba? You have your pronation, pronator teres, you have pronator quadratus also. And its counterpart is actually here, your radial, your extension, and supination. So you have supination. Yan. Magulo lang, pero that's the way it is. So there's always opposite. You have flexion, extension. I want you to connect that in the pronation, supination connection. So you have now patient kung may median nerve injury, may weakness on pronation, but the muscle will be more on, maybe the forearm will be on supinated, and flexion on the median will not be prominent because the one that would be is actually on extension because mas malakas si radial. So let's look at and analyze the median nerve palsy. So the median, if you ask the patient to bend or flex the fingers, ganyan, di ba, ang normal. Pag pinaano mo na siya, if you ask the patient now to flex again, may iwan yung dalawang daliri. This is what I'm telling you earlier. This one, the claw hand, the difference, because in claw hand, naka-extend dapat. But in median, you ask the patient to flex, yan, ganyan lang siya. Active or papal Benedictine sign, as you may say so. Because yung FDP here is paralyzed, FDS here, FD is paralyzed, but the extension are not paralyzed. So it's gonna be opposite. So hindi mo ma-flex, pero ma-extend niya kasi mas malakas si radial nerve. So it would appear that way. Is that clear? Yes, that's clear. Another consideration now is to differentiate. How will you differentiate lower trunk from the ulnar, pure ulnar? So let's cut it ulnar. Oh, how will you differentiate ulnar from lower trunk Klumpke's palsy? Again, you differentiate it by the number of nerve involvement. Sa Klumpke's, ano affected? You have your medial cutaneous to the arm, medial cutaneous to the forearm. So may sensory deficit ka here, may sensory deficit ka here, tapos naka-claw hand pa siya. Right? But in ulnar, naka-claw hand siya, pero okay ang sensation here, okay sensation here. It's only on the ulnar distribution. Okay? Is that clear, guys? That's how you differentiate the claw hand of lower trunk and the claw hand of the ulnar nerve. Okay? So let's proceed now with your radial. So paano ba pag kinat mo si radial? Very basic lang, di ba? So si radial ay extension of the wrist, extension of the elbow. So malamang, walang extension, ano ang mas malakas? Flexion. Tama? Etong elbow mo mas malakas, right? Compared sa extension. So therefore, what will be the predominant posture of the patient with radial? Naka-wrist drop. Pero ang wrist drop mo, naka-flex si elbow. Bakit? Kasi pag naka-extend yan at umikot yon, ano na yon? That's a waiter's tip deformity. So you have to be careful with that. So ito, naka-wrist drop siya pero naka-flex si elbow. Okay, so that's how you differentiate waiter's tip from the wrist drop of the radial nerve. Is it clear, guys? Are you appreciating how the movement patterns and the deformity will give you idea whether it is of the higher level or the more distal involvement? Clear? And of course, with your axillary, what are the muscles innervated by the axillary nerve? Your deltoid and your teres minor. So commonly, you have your shoulder abduction, right? Shoulder abduction. So very easy lang kasi yun lang yung titignan mo. Those are the common on this posterior cord. Okay, there's one more which is your long thoracic nerve. So how do we cut it off? So let's look at the long thoracic nerve. What muscle innervated by the long thoracic nerve is your serratus anterior, right? And how do you locate it, the long thoracic nerve? If you're going to look at my fingers now, if you look at it serrated, right? So serrated, my imagination. That we call to remember the name of the muscle, serratus anterior. If you're going to put your fingers, try to reach on the back, which is your tip of the scapula. That would be your attachment of serratus, and the first 8 ribs, that would be your attachment of your serratus anterior. And if there is weakness, there would be no attachment or weakness to the tip of the scapula, and therefore there would be what? A winging of the scapula. Okay, so you look at now on the posterior aspect. So, okay. So that's how to understand the brachial plexus and integrating that on the clinical aspect, because we don't examine the nerve, but we do examine the muscle. And we grade them. You should remember your grading again, your 0, 1, 2, 3, 4, 5. And if you're going to apply that on examining patient, is that you have to screen the patient for a grade of 3/5. If the patient can do that against gravity, if cannot, then you apply the concepts now on horizontal positioning, which is your grade 2, right? So in the board exam, they would always ask for that. What is the position of this particular joint if you are going to test for a grade 2/5? So not anymore for grade 3/5, not anymore for applying resistance, but actually differentiating a grade 2 in terms of positioning a joint. So if you're preparing for the review, yun lang, focus mo na yun doon. Okay? And if you're preparing for the review also, what are these muscles here at a particular joint? Di yun lang yung focus mo. For sure, there will come out the board exam that is common tested muscles rather than rare. If there will be rare, then you just have to do an intellectual guess, right? And again, that's the application. Of course, how are you going to apply for that? The concept, the range of motion. You know that if there is muscle weakness, there would be not able to complete the range of motion. That's why you put them horizontal, hoping that they will complete the range of motion, gravity eliminated. If not, that's the time you use the minus, pero I don't know if it's that applicable, but nevertheless, you still use that, you minus, and in terms of MMT. But the criteria for MMT would always be gravity, the range of motion, and of course, your resistance, right? So, patient able to complete the range of motion against gravity. That's a full 3. But if the patient able to move against gravity but not full range of motion, sometimes you make use of 3 minus, right? Or for example, a grade 2, complete the range of motion, gravity eliminated, that's 2. But what if not able to complete? So you add now minus, not able to complete it, right? And so that's the story behind that, to not to just memorize it, but understanding it. Okay, and of course, what is the application of this concept is in terms of what? In terms of splinting, right? And you know what would be the application for splinting is we want to support the joint, right? So if the joint is actually on wrist drop, you have to support it in a functional position, right? And of course, prevention. That's why you have to prevent what? Contracture o yung paninigas ng mga litid, all right? And support the joint in a functional position, okay? And the naming is just easy because the name of the orthosis will depend on the joint. So you have the wrist hand orthosis, you have the elbow orthosis, you have the shoulder orthosis. So the naming is actually depend on the joint it support or assist the movement. So other than prevent contracture is assisting the movement. Okay, so that's the application of this to connect on your recommending what will I do now to my patient with peripheral nerve damage. And of course, you have no choice but to review again your peripheral nerve injury pathology, which is actually your Wallerian degeneration, because it will goes with prognosis, right? You still remember, if the whole axon is involved, the whole neuron is involved, or it's just the connective tissue is involved, right? The more structure, the deeper structure involvement, the poorer the prognosis. And that's why you have encountered the neuropraxia, the neurotmesis, and the axonotmesis. So these are now your pathological application. So you know that there is damage, but you know that there is damage. Paano natin palitin to? You know that there is damage, but the point is, you have to understand the prognosis for that. Ay nahalo na siya. Anyway, sorry for that. Okay? Any questions so far? Wala? Okay na tayo? Are you good? Anakel, can you stop the recording now? So we have now the recording for this session. And just send me a copy.